Well, I became a member of the forum in 1986. Actually, I had at that time I was already faculty in Maulana Azad Medical College, and I had applied for trainee fellowship in neonatology, and I got that fellowship under Dr. Mehrbaan Singh, and at that time he was the secretary of the forum. So at the end of the fellowship, he inducted me in the forum. And so since '86, I have been a member of the forum. So this brings me back to 1978, when I joined pediatrics as a postgraduate. And at that time, my guide, Professor Rajput, he was trained under Dr. Pohawala, who is the father of pediatrics in India. He gave me a topic, knowledge, attitude and practices of traditional birth attendants for perinatal care. So I was supposed to go to primary health centers and district hospitals during the weekends. And so I would go there using the state transport bus, and then the last part of the journey would be through something like hitchhiking on tractors or other modes, and then spend the day at PHC and district hospital. Now, two important things that this did was, number one, it introduced me to the pathetic state of newborn and neonatal care. And the second important thing it did was, it exposed me to the healthcare delivery system in India, which also was in a pathetic state. So, looking at the times at that time, neonatal tetanus was rampant. Immunization with tetanus toxoid was something like 30% or even lower. So, our hospital used to be flooded with cases of neonatal tetanus, asphyxia, sepsis. Unfortunately, the neonatal care at that time meant that there was a small area by the side of labor room, which was confined to care of those inborn babies who became sick or who were considered small. For the babies who were, a large majority of babies who were brought from outside, there was nothing except that they got admitted into the general pediatric ward. So looking at that and looking at the healthcare delivery system, I thought that I must do something for improving the lot of the newborns within the existing healthcare delivery system and try to do something about the system. Yeah, so NNF was founded in 1980. So before that, while I was doing post-graduation, as I said, that basically it was neonatal tetanus, asphyxia, and it was sepsis, and the state was really pathetic, and they were all admitted in the pediatric ward. So there was no defined space where these babies could receive the basics of essential newborn care. So when I was selected through UPSC and I joined Maulana Azad Medical College, and then I had this trainee fellowship with Dr. Mehrbaan Singh. In 1988, I had an opportunity to get the Commonwealth Fellowship, and I spent 3 months in Liverpool. And I got an exposure to the healthcare delivery system of Britain and the neonatal care that they provide. I could visit a lot of neonatal units and see the neonatal care there. And so I felt that there is a lot of things which is doable in India, and if given the opportunity and the position, I would try to do as much as is possible.
Wonderful, sir.
I was elected as a joint secretary in 1995, and at that time it used to be 2-year tenure. So 95, 96, I was the joint secretary, and the joint secretary graduated to secretary automatically. So 97 and 98, I was the secretary of the forum. The joint secretary also doubled up as the joint editor of the forum bulletin and also as treasurer, while the secretary doubled up as the editor of the bulletin. So that is when I had my first stint with NNF as secretary and joint secretary. And then I was elected as president in 2003. So 2003 to 4, I was president elect. So it used to be 2 years term. And then 2005 to 6, I was president. And then 2007 to 8, I was member of the governing body as immediate past president. So the 6 years as president and 4 years as secretary and joint secretary. So I spent 10 years as office bearer of the. When I joined as joint secretary, at that time, we were sort of trying to develop teaching aids. So these teaching aids consisted of slides and the manuscript, so that there could be uniform teaching on common neonatal problems in all medical colleges. So how it was done was, an expert group meeting was held in the after the NNF convention at Chennai. Around 22 people who were the leading neonatologists at that time. So we all sat together, and the topics had been distributed earlier. So they made the presentation, and then the discussion was done. And after that, the finalization was done. So I was involved with that production of the teaching aids. These later were quite useful. They were distributed to different medical colleges. They were also tested and validated. And subsequently, they reached a lot of medical colleges, and also these were used for subsequent training at district hospitals. Then the other thing which was coming up was neonatal resuscitation workshops. See, the difference before 1992 was that neonatal resuscitation was not standardized. The NRP came in the global scene somewhere in 1992. And around that time only, the Neonatology Forum also took up. And in 1993, we had this training of trainers, and I was trained as a trainer for the NRP. And we started doing a lot of NRP workshops. So NNF was the sole body which was conducting the NRP workshops. And we did almost, every month there used to be some workshop at some place or the other. And the other important group in resuscitation is the obstetricians. So we also did a workshop at the FOXY annual convention at Kanpur, and a lot of obstetricians joined that. And for the first time, when they listened that 2/3 of the asphyxia is antenatal, before birth, they were quite taken aback, and many of them were enlightened, and many of them felt more responsible for asphyxia. So that is what we did at that time. And then we were also looking at the education part. So there was a subcommittee on undergraduate curriculum. So I was part of that subcommittee, and we formulated competency-based curriculum for neonatology training at that time, and also like deciding the percentage of time and training that should be done in neonatology as part of pediatrics. So all that was also looked into. Then I was also a resource person for the CSSM. That time there was this national program, Child Survival and Safe Motherhood. Now it only had a mention of newborn care, and it said that essential newborn care should be provided. how and in what way, nothing was spelled out. But the good part was that under this, essential newborn care equipment was being supplied to PHCs. And so we used to operationalize that. But most of the times, what we found was that this equipment used to be locked in the store. And people feigned ignorance that it even existed. The medical officer would say, "Oh, is there some equipment like this? I am not aware." So something like that. So that was the. But we were trying to make a beginning into supply of essential newborn care equipment. So this is what I was involved in as a joint secretary. Then 97 to 98, I was secretary as well as the editor. So being the editor, I took this opportunity, and I used to write editorials on having an extramural neonatal unit in all medical colleges, taking care of outborn newborns, doing something about neonatal mortality. So all those things, I wanted to increase awareness about that. And I joined in 97 January. By 97 March, we had this collaboration with the Government of India and WHO on preparation of a manual for primary neonatal care. So a group of around 25 experts from NNF, I convened a meeting of all of them at Ahmedabad, and there we had distributed all the topics on primary neonatal care, and the presentations were done, discussions were done, and we came out with a manual on primary care of the newborn. It was submitted to the Government of India, and in addition, I thought it will be lost in the Government of India files, so I also printed it in the NNF bulletin. So that is what we did for the primary neonatal care. Then very soon the WHO and Government of India asked us to do a project on strengthening neonatal services in northeastern region. So what it involved was supply of essential newborn care equipment to medical colleges in Northeast, and training, and also to the district hospitals in Northeast, and training of the pediatricians and the medical college faculty in neonatal care. So these were 3-day workshops, and we did 4 of these. So one was done in Dibrugarh, then the other in Guwahati, then in Silchar, and one in New Jalpaiguri. At that time, the northeastern state was in turmoil, and so people used to be scared of even going or thinking of going there. And for quite some time there's heavy monsoon, but somehow we had a good team in NNF, and some people whom I could always rely. So we always had a team of 3 or 4 people from NNF, and we used to go there, and one local faculty from that region. And this is how we did those workshops. So what we did was, first day it used to be neonatal resuscitation. Then second day it used to be talks on newborn care, and also demonstration of the equipment supplied there, and how to use it, and installation of that equipment. So this is what was the format of the workshops, and these we did, and we found that so long as there was a space to keep a sort of designated nursery in the medical colleges, probably there was some scope of utilization of these and some future in sort of betterment of neonatal care. So this was another activity which took quite some time. Then we collaborated with CARE and this international agency, and at Bhopal we had a training workshop for village level workers on care of newborn at village level. So that was the workshop, and we were 4, 5 or 6 faculty from NNF. We went there, and the CARE had sort of mobilized the frontline workers at village level, and the training was imparted. It was given in Hindi, obviously, but it was quite successful, and we found that the frontline workers, because they had to do this job, they were very enthusiastic in learning. The NNPD I came after this. After 98, an NPD also came and the database was. Yeah, so as a secretary, is at that time we used to collaborate with FOXI, with Government of India, WHO, UNICEF. Actually, NNF was the sole custodian for neonatal care at that time. So we collaborated with all, but we were the persons who used to push it. So we used to push it with the government and with the international agencies. The neonatal resuscitation program, it made a major difference. It made a major difference. At that time, before that, even the IPPV bags, the MO bag was also not available in India. Neonatal resuscitation was in a bad shape. With the introduction of NRP, the bags were also manufactured in India, and earlier they used to be imported. So the Indian manufacturers also started manufacturing these bags, and resuscitation took off as a sort of systematic procedure. That was very important, and there was a attempt to bring the government on board and to have commitment for newborn care, to do advocacy for newborn and try to do more and more activities for the welfare of the newborn. So at that time, somewhere in the late 90s, that was the focus, and the other focus was to have more and more level 2 neonatal care units. Neonatal ventilation was coming in some way, and ventilation was also getting introduced at that time. Well, the challenges are always there and they will always be there. The challenges are posed by the system and by the people. So, the system is driven by people. People have certain demonic traits and certain divine traits. They are present in everybody. The demons and divinity is inside the mind. Now, when this demonic trait becomes so overpowered that it leads to selfishness, one-upship, jealousy, pulling down others, weakening the system for self-interest, then when such people are in power, the system is badly affected. So these challenges have been there and will always be there. The way to swim across, the sort of guiding light is the sole objective. So for example, I was very firm in my objective. I wanted to serve humanity. So we think that medical education starts when you get into MBBS. The hard part of it starts truly when you get into MBBS. But the more important soft skills are what you develop much earlier. During your upbringing, during your exposure in the societal environment, family environment, the values that you imbibe. So whether the so-called divine and demonic traits that you are able to inhibit or nurture. So it is those things which make you capable of facing any sort of challenge. So I believe that being third in generation of doctors, with sort of now we have 5 generations of doctors, almost 50 people. So probably that background also helped me a lot, and we were very focused on serving humanity as a true goal of life. Probably that is what helped me in coming across all the challenges. Thanks. By the time I had spent 4 years in NNF, I had visited a lot of PHCs and district hospitals. And as I said, during my post graduation, also I had this opportunity to see the healthcare delivery system. Later on in CSSM, I was also involved in operationalization of the newborn care at district level. And we used to supply the equipment, but we found that the persons there were not interested. And gradually, and I saw the state of the extramural newborn, the referred newborns, the pathetic state. So I was quite convinced that unless we have a neonatal unit at district level, the newborn care would not take up. Unless we had a extramural and referral newborn unit in every medical college, the newborn care would not seriously take off. So I thought first it will be important to do it at district level. And when I was president elect, I was invited, as used to be the trend. I was invited to all the meetings, and I would always make it a point to go. And being Delhi based, so all the Government of India meetings, the UNICEF, WHO meetings. So there I used to tap these partners. I used to sort of interact with them, like the Government of India, the MCH divisions, so the people used to be there. So I used to float this topic and try to see their response. And similar thing I did with WHO and UNICEF. At that time, unfortunately, the environment was such that everybody was talking of only home-based newborn care. So I used to say that why not have a newborn care unit in district hospital? And they used to say that nobody utilizes the facility of a district hospital. So I didn't understand how can we reduce neonatal mortality when the death reduction is our goal and the death will happen in the hospital. So when I got the opportunity, when I was president, I had this good friendship with the UNICEF chief of health. And one day we went to him, me and the secretary, I took him along everywhere. And I talked to him about this establishment of newborn care units. And in every document that WHO produced, there was a mention of newborn care at facility. But how it would be done, that was not enunciated. So we talked to him over a cup of coffee. And I said that, see, we want to have a model of newborn care units in 10 districts. Let us do it in 10 districts. And if these work, so in this we should have provision for space, for the physical infrastructure, equipment, manpower, so everything. All these should be there. We should put this as a model. The UNICEF should support it. The Government of India, the framework, the NRHM framework mentioned that there should be such a facility. But how it will be done, that was not enunciated. So I said that this is what we can do. We have the atmosphere to do it. So he initially he was not interested. He said, okay, where do you want to do it? So I said, let us do it in all the at that time they used to be called EAG, and before that B Mathur state. So I said, we will do it in Bihar, in MP, UP, Rajasthan. From there we'll take 10 districts. So then he became alert. He said, everybody comes to me with models for Gujarat and Tamil Nadu and all those states which do well. Why do you want to do it in these states? So then we clarified that, if it works in these states, then it can be scaled up to the entire country. So then what used to happen was, from the center, NNF, central NNF, like I used to go with my secretary, Dr. Saluja, and there used to be a sort of an architect from UNICEF, a person from UNICEF, the state UNICEF was involved. Then we used to involve the state government functionary in health. And this used to be the team. So first we would go to the state headquarters. We would interact with this secretary, health secretary. Then we would take this team. We had identified the districts. We would go to the district. there, right then and there, the architect, he used to find out from the existing district hospital where this unit could be created. So that he used to make a sketch then and there, and then we used to come back and we used to finalize our reports. A budget of 44 lakhs minus the manpower, that was there. We had prepared that budget. Actually, when we were doing this, the district units, then subsequently when the district units got prepared, we used to go there and hold workshops to train the medical officers who were sort of recruited for it. So although we had planned 7 medical officers, but most of the states provided 4 medical officers, and they used to be trained. So medical officers from district adjoining the place of training. The place of training used to be the district where a neonatal unit was already constructed, and there we used to hold the workshops. And these used to be these 3-day workshops. So our pattern was more or less decided. First day we used to do the resuscitation. Second day we would do the problems in newborn care. And then the third day we would do the demonstration of equipment, how to use it and all those things. So this exercise was done in a large number of districts, and that is what we were busy with. And the other things that I did as president was we had this sort of district units, but these would not function unless there was comprehensive newborn care for the district. And so we had emphasized a comprehensive newborn care sort of model, in which the district hospital was the hub hospital, and then there was a stabilization unit in the primary health centers, and there was a provision for transport. So a transport module, the government of India asked us to prepare a transport module, and we prepared a transport module, and we also did a training on it for national trainers, and subsequent trainings were done. By that time, personally, I was doing research on transported neonates, and there were at that time many modules on neonatal transport, mostly from West, the safer transport and the nicer transport, and all those things were there. Because I used to cater to the extramural newborns, those who were transported, I felt that they came in a very bad state. And it was not practical to apply these modules routinely in those newborns. So I came out with a very simplified method and a score to score how a particular newborn would do after transportation. And that is how we came out with this top score, in which we just looked at temperature, oxygen saturation, the perfusion status and sugar status. And so our module was based on stabilization of these 4 units, these 4 parameters, management of these 4 parameters, checking them pre-transport, during transport and post-transport. So we came out with a very simplified module for neonatal transport also. So that was another important activity that we did when I was president. At that time, there was also this nursing issue which was coming up. Unless we had good nurses, we could not have good newborn care. So we had nurtured some nursing leadership. We started having one nominated governing body member as a nurse. And with that, we also organized an international conference on neonatal nursing. And, we had participants from Australia, USA, UK, New Zealand, all the developed countries had our Indian representatives. I think there were around 40 countries which were represented in this nursing workshop, and our nursing leadership got a good boost. So that was another thing that we did. Then we did a collaboration with ICMR, the NNF ICMR research methodology workshop, in which we trained a large number of national trainers. This was a 2 or 3 day workshop. The venue was AIMS, and we had faculty from ICMR and AIMS and AMC and other places. In the transport, we collaborated with CATS for Delhi. So I was a member of the CATS committee. They wanted to extend it for perinatal use. So at that time, we pushed it. Later on, we also had a training program for the driver and the health attendant of the CATS ambulance in newborn care. So that was another thing that we initiated. Then the RCH program was coming up in this period. Although the RCH program, I was invited to the midterm review of RCH, and the IMNCI was also coming up. So in all these meetings, I was invited as in all these high-powered meetings. And I always ask this question, that we must upscale the neonatal units at district level. Otherwise, neither the IMNCI nor RCH is going to be successful. So that was the time. Then we had this International Pediatric Association, and its director was coming on a visit to India, and we interacted with her, and we said that it is a country like India, we should take up the leadership to create a forum, an international forum for newborn care, because we face the maximum number of deaths and all those issues. So she sort of somehow got this idea, and she invited us to this global initiative on newborn health. This was by International Pediatric Association. So I had gone there, and me and Dr. Saluja, we had gone there as country representative. At the same time, there was this PASS meeting. So that at the venue of PASS meeting, this global initiative on newborn health, that was also held. And also a program for global pediatric research. So we participated in that also. That used to be led by Alvin Zupersky. It was very good experience, interaction, and we sort of put the Indian perspective into the global perspective, and it was well appreciated. So at that time, most of the people who were members of the NNF, they were people who were actually doing neonatology, who were actually every day struggling with care for neonate, struggling to have more resources for neonate, more people for neonate. So these people were very committed. So they made efforts to have their own unit people involved. And it was very early realized that without nurses we won't be able to do anything. So there was a lot of emphasis on having nursing members. So we had those nurses members. And then involving the obstetrician. So a lot of effort was made, because there used to be a resistance also. The obstetricians, they had their own forum. But we used to try to make effort to have inroads in that. And of course the young blood, the PGs, they were, all effort was made to introduce them to NNF, but it was all quite difficult. We used to put ads on, regarding NNF activities in Indian pediatrics. However, there was no such active sort of pursuing of membership, or campaigns for membership, or political drives for membership, or like, saying that, you make 4 members and 2 will be free, something like that. So those things were not there. But yes, the people who were keen to become NNF members, they were very readily enrolled as NNF members. There started a sort of surge in interest to join the neonatology forum, because at the time that I was talking of, like in 2007-8, at that time, NNF was the most active professional one. So a lot of people got attracted to Neonatology Forum with a lot of varied interests and motives. People found it as a good platform. People found it good to be involved with the activities. People thought that there were a lot of activities happening in the forum. So a lot of them started joining. A lot of people who wanted to be leaders in neonatology, they also started coming in. Earlier, although the NNF it consisted mostly of people who were actively doing neonatology, but later on people who may be having some interest in neonatology, but they may be practicing less of neonatology, but they wanted to join the forum. So that way the membership increased. And with that, the involvement of people increased. Earlier, most of the members were from the government sector, from the leading units. Around, I can say there were 20-25 big units which were doing good neonatology in the country. And most of them were from the government sector. But then a lot of people from good private sector, they also started joining. And so the expansion areas included these, the pediatric practitioner and the private sector doing neonatology. They also joined and they took a lot of interest in the forum. Yes, so maybe, like I said earlier, the term for a secretary or a joint secretary or a president was a long term. It brought with it a sense of responsibility, a sense of being answerable, a sense of being able to plan a project, a long-term activity, and being able to fulfill that also. So that was one era. Later on, as more people became aspirants, and it was changed to a one-year term, and so more people got involved. So that was a major change. The tenure for the NNS office bearers, that was reduced or truncated, and it had its own plus and minus. So that was a major change that I see in NNF. And in the earlier time, NNF was the sole custodian for newborn care, and we can take it as a sort of as our achievement that we got more bodies, the governments and international agencies aware of what is newborn care, what are newborn issues, and we got them involved into neonatology. Right from the beginning, because NNF was focused on its objective, and people were always struggling with the day-to-day issues, the problems of neonates, and the responsibility of how to improve the lot of the neonate. So right from the beginning, there were committees like, say, something like Primary Care Committee, Accreditation Committee, the Facility-Based Newborn Care Committee. NNF Industry Relationship Committee came when the influence of the breast milk substitutes started harming breastfeeding. So that committee also came. And there was website committee, and various task forces used to be there. Like we had a task force for creating the undergraduate teaching aids, and a committee for undergraduate curriculum. So the committees were always a part of NNF. Task forces were there. They were given a focused job, and they would do it. So, for example, when I was secretary of NNF, I felt that the interest amongst the postgraduate residents in pediatrics, at that time the DM was had not started anywhere. And I found probably the PGI was the first place where they started. And at that time I felt that there should be something which will motivate the postgraduate in pediatrics to do something more. So I proposed this idea that we should have a postgraduate quiz in neonatology. by NNF. So this first PG quiz, I think it was started somewhere in '98. So I was the first coordinator for the NNF postgraduate quiz, and I was told that we don't have funds for this, and I should not use funds for this. So I sort of made an infrastructure consisting of all the heads of departments of medical colleges, and then when I had become secretary, I started feeling that we should have state branches. Before that, we started state representatives. So there used to be state representatives. We used to nominate state representatives from each state. There used to be an NNF representative for that state. Then I started doing the state branches. And I remember UP was the first branch. I was personally there. I inaugurated it, and at Rajasthan also I was personally there. And besides others like West Bengal and Tamil Nadu on their own also, they were coming up. So a lot of branches had also come up by that time. So I made those state representatives or the presidents of the state branches as the divisional coordinators, the state coordinators, and then the NNF governing body members, they became the zonal coordinators. And then the final was held at the annual convention. And this is how we started the NNF postgraduate quiz. And the way the students performed, the members were really surprised at the level of questions and the way they could answer it with ease. So that was a very good and concerted effort by the NNF. And then when I was president, we always kept thinking of involving the nurses. So I thought that now we should have a nursing quiz in neonatology. So as president, I started this nursing quiz in neonatology. We already had the infrastructure for the NNF PG quiz. On the same lines, we started the nursing quiz, and it took up quite well. So this is how the concerted efforts of members and of people who are given responsibility, they used to do it, carry out with responsibility, and things used to happen. Yeah, so say earlier, like when we had this focus on primary newborn care, so that time we brought out the primary newborn care guideline. And then we also had a group which was working on equipment. There was a group which used to work on nursing, and they used to bring guidelines and teaching aids that used to be there. The research methodology that was there. NRP came in a big way, and it sort of brought uniformity in resuscitation, transportation. There were guidelines. There was a NNF IAP collaboration, and we brought out combined guidelines. So all those publications were there, and the members used to find it very useful. In fact, the first document that came with the inception of the NNF, and that was on the levels of neonatal care and what is the requirement, the space requirement, and all those things. That came with the first founding meeting of NNF. So that the blue colored booklet that used to be there. And whenever we wanted to sort of have a upgradation of a unit, or say ask for level 2 unit, how much space is required, how much personnel is required, so all that could be quoted from that document. So a lot of utilization of all those documents was made by the members. Well, you see, right from the beginning, NNF had a good collaboration with the sort of foreign collaborators, in the sense that a lot of Indians were doing neonatology abroad. So, like some people like Dr. Vidyasagar, Dr. Sunil Sinha, Dr. Vinod Bhutani, they used to be regular visitors to the NNF, to the annual conventions. People used to personally be in touch with them. They used to help people. There used to be a group of people who wanted to go abroad. So people like say, Dr. Vidyasagar or Sunil Sinha, Vinod Bhutani, they would help people settle abroad. They would guide them. And So a lot of collaboration occurred with the faculty abroad, the Indians who had settled and made a name for themselves in neonatology abroad. So they all were in touch with NNF.
But were sir they directly involved in training the youngsters or?
Yeah, so for example, the NRP, for the NRP, when the NRP was first introduced in India, so we had this the faculty coming from US.
Even for the first ventilation workshop.
For all these workshops or any state of the art thing, so those people because they used to be regular visitors for the annual convention, so they used to be involved, and they used to be very active and very helpful. So they were all there. But one name which is very important is that of the UNICEF Health Chief, Marzio Bebel. So he collaborated with us when we were finding no other way to sort of have newborn care at district level, so sort of have formalized facility-based newborn care, a newborn care unit. At that time, this was considered a laughable proposition. People would say, oh, this is not feasible. At that time, he listened to us, he helped us, and we could do it. By 1992, we had this NRP guidelines. Before that, the management of asphyxia was sort of dependent on the person doing it. So, for example, there was no embu bag. If positive pressure ventilation had to be given, some enthusiastic resident would do a mouth-to-mouth resuscitation. And they used to be really sort of committed to it. So they would do that. And they would have an umbilical line. So those were some of the efforts which some of the enthusiastic residents, they used to do. Otherwise, as a routine, it used to be just administration of oxygen. And maybe at that time, the glucose and soda bicarb, they were given rather early. Because although the pathophysiology was understood, but those details of pathophysiology came later when it was found that these things are not to be given early. So that used to be the state of resuscitation. And then this improved dramatically after the NRP guidelines came. And then with each new textbook of resuscitation coming up, the NNF adopted that. So resuscitation really changed at the global pace in India. It's really a very long story. So in the 80s and pre-80s, when we were postgraduates, at that time, the only way to warm the so-called inborn nursery, which used to be a room adjacent to the labor room, that was using heaters, hot water bottles. And then, somewhere in the late 90s, the heat convectors came in the market. And they were found to be sort of very good in the sense that they warmed the room very quickly. So then a lot of them started getting used. Although we realized the problems associated with that later, but at least that they could provide the warmth that was needed, much needed. Then subsequently, we had this somewhere in 95, 96, we had this WHO talking more on hypothermia and giving a WHO classification. So I took up a study on the evaluation of WHO classification of hypothermia. Like it said, mild, moderate and severe. So did it link with mortality? So we did that study. And we established, like earlier, the ways of rewarming were also very variable and not clear. So they used somebody who used to say it should be slow rewarming, and then the others used to say no, it should be rapid, and then it was felt that maybe it is a combination of slow and rapid, but nobody was clear. So when we took up this study, I looked up at the literature. I couldn't find much, but then I thought of a very simple, a common sense sort of way of dealing it. So what we did, we used to sort of classify whether at admission, whether this outborn he was in mild or moderate or severe hypothermia. we used to put them in a servo mode, skin mode, attach the probe onto the abdominal wall, and we used to monitor the time. How much time did it take for the skin temperature to normalize? So that is how we established the time for normalization of the skin temperature in mild, moderate, and severe hypothermia. We also saw how it clearly correlated with mortality outcomes. And it was very obvious that initially the baby was being warmed rapidly till his temperature, the skin temperature came to normal. And then he was steadily and slowly being warmed. His core was being warmed once the temperature was achieved. So that was the beauty of use of servo warmers. And also the servo warmers were also available around that time only. So this is how we did our study on this severity of hypothermia, the WHO severity and its validation. And this also led us to identify the TOPS parameter. And as you were saying, there are around 20 to 25 studies on TOPS nationally and at international level, which have validated the TOPS score and its utility in transported neonates. Earlier, it is related to certain other developments. In the 80s, the third generation cephalosporin was something new which used to be imported. So it used to be imported vials which used to be there. Because at that time only ampicillin and gentamicin were available. Then very often they didn't work. So third generation cephalosporin became available, and the more advanced aminoglycosides, they became available. At that time mortality used to be high, and the babies in sepsis, they used to be really in severe sepsis. So what I observed was, because I was having these outborn neonates who came in florid sepsis, in septic shock, in DIC, organ dysfunction. And I was exposed to the use of exchange transfusion when I did my senior residency in Kalavati Hospital. So there was one study which did exchange transfusion in sepsis. So I started doing. We did 3 or 4 studies on exchange transfusion in neonatal sepsis, and we found dramatic results, particularly in neutropenia, in septic shock, in DIC. The results were dramatic. So we started using this exchange transfusion. It gave us very good results. But then there was this fear of HIV which came, and then the regulations on blood transfusion and other things were coming up, and more antibiotics were becoming available. Then there was an era of antibiotic stewardship. At the same time, I had a sort of a limited number of beds, but I was one of the limited, if I may use the term, only newborn unit, or maybe some other units were also admitting the extramural newborns. So there was a lot of pressure of beds on me. So I was always constantly thinking of ways, devising ways to shorten the stay of the newborn. Breastfeeding, shifting the baby to breastfeeds early, exposure to non-nutritive sucking, all that was part of that. So what I started looking at that time, in the adult literature, they were talking of the appropriate term or duration of antibiotic. There were very limited studies, and there was hardly any study in the newborn. I started looking at literature. The literature was difficult to find an answer. The existing recommendations were formed at a time when the only objective, the end point, was sufficient treatment. Nobody looked at whether extra antibiotic was given or not, whether the duration of antibiotic was optimum or not, whether extra antibiotic harmed the baby or not. Even that was not looked at. So I did a series of studies, one on neonatal pneumonia, one on sepsis, one on meningitis, in which I looked at the optimum duration of antibiotics that can be given the selection of patients which could be used to give short-term therapy, what are the endpoints that can be used, what are the practical parameters for diagnosis that we are using for giving antibiotics. So we have to use that only. So how practically we diagnose, how practically we are starting antibiotics, and then if we are starting, then how long to give, what minimum duration can be used, and then say other parameters, lab parameters like procalcitonin and other things which can be utilized, like for meningitis, utilization of clinical features and this CSF cytology and other things. All of them were utilized to sort of have some scientific evidence on how to have an optimum duration of antibiotics for the newborn sepsis. And we have still a long way to go. Still a lot of work needs to be done in multicentric trials to decide what is the optimum duration of therapy for different clinical syndromes of neonatal infection. Unit. For warming, it was predominantly incubators. But I think by late 80s, the radiant warmers had started coming, but they were crude. They used to be sort of air mode only. Then gradually we used to interact with the manufacturers. See, we also had a corporate membership. So the manufacturers and the forum had a close interaction. So we told them that have a servo mode. And then they started also adding the set temperature display and actual for skin mode as well as for the servo mode. So all those things, those advancements started coming for the incubator, for the warmers. And then by 90s, the ventilator was there. I was the first to procure the Draeger Baby Log 8000 plus ventilator somewhere in the early 90s. And I found that the lung functions were something which were tremendously useful. They could curtail your requirement and frequency of ABG and lead to better monitoring bedside in real time. So I got a study done on using the minute ventilation as a surrogate for PCO2. And already the oxygenation part was available through the pulse oximeter. The pulse oximeter came somewhere in the 90s. And quickly it was used by all the units. For PCO2, we required the gases. And the gases would take time. And I remember the residents, sometimes they used to run to different units and labs, and sometimes our resident would go to Pant Hospital because their cardiothoracic unit, the ABG was always available. All those things were there. But with this MV, so we found that this MV, minute ventilation, correlated very well with PCO2. We published that study. And we routinely started documenting the lung functions in our ventilator charts. And we found that that was very useful in preventing the ventilator-induced lung injury. So for ventilation, the use of lung function, availability of lung function was a very important step. The pulse oximeter came in a big way. There are other things which came and went. For example, the TCPO2, the TC, that came. It didn't last long. So there have been equipments which came, they didn't make an impact. Cooling came, and cooling somehow has not established itself that well. So this is how has been the flow of equipment. High frequency oscillatory ventilation we acquired quite early. I presented a paper on the utilization and the positive impact on ABG in the international the Asian conference on pediatrics at Bangkok, and the paper got an award also. And we found that it impacted the ABGs when the conventional method of ventilation could not. But the ultimate effect was not there for all the patients. So a group of selected patients had to be used for that. And then the CPAP came in a big way, and the oxygenation the interface, they started coming. And the cannulas, oxygen cannulas, they started coming in a big way. And the use of CPAP and the oxygenation cannulas to prevent apneas, they were a big help. So this is how the equipments have really developed very well in